Hi, welcome to our program. I'm Dr. Lewis Hassel, Professor of Pathology at the University of Oklahoma Health Sciences Center. And our program, Digital Slide Review and Sign Out, is part of the Digital Anatomic Pathology Academy, a joint venture with Path Presenter and the Digital Pathology Association. Today's case is a quick one. It comes from the realm of gynecologic pathology and is a circumstance that arises sometimes as we follow patients with various diseases. In this case, the patient had a history of endometrial intraepithelial neoplasia and was seen in follow-up for that disorder. Uh, and this brings up the question of how EIN is managed in various settings and circumstances. And so I thought just briefly we would review that. And there are several treatment options that present, and they vary somewhat based on the age of the patient, their desire for further fertility, the risk factors that they may have associated with EIN. So the main option in most situations is surgical. Performing a hysterectomy along with oophorectomy removes any further risk of progression or a development of carcinoma. But in some circumstances, a medical approach seems prudent if the patient's a poor surgical risk or desires to maintain fertility. The use of oral or intrauterine device progestins has been promoted as a means of suppressing and potentially eliminating the presence of the intraepithelial component and allowing the patient to proceed with other gestational or other activities. It, of course, requires some degree of significant follow-up to make sure that that is been adequately managed. And when speaking of that, the usual scenario for follow-up is to weigh some of these risk factors. Of course, any of these are essentially factors that promote or are associated with a high level of estrogenic activity, obesity, irregular menses, nulliparity, polycystic ovary disease, unopposed estrogens, and so forth. But also diabetes and patients who have a history of Lynch syndrome or in other family members with endometrial carcinoma. And of course, there's always the risk, because this is a challenging initial diagnosis, that the initial biopsy was undercalled and referred to as EIN, when in fact it perhaps met the qualifications for carcinoma. So with that, let's take a look at our patient's slides, which were seen in follow-up. Here we see low power magnification of the curetting sample taken from this patient. And I will just point out at low magnification that we can see there's a bit of glandular complexity here. And we have this sort of pale bluish stroma. And both of those features at low magnification should tell us something. The bluish stromal change tells us that this patient is probably on progestins, and she's having some sort of a progestational effect. The glandular contours, even at this low magnification, slight papillarities and so forth, should alert us that there is a glandular proliferation going on. So in usual circumstance, when we get a progestational effect in the endometrium, we see something that looks more like this area here, where we have a dense area of decidualized stroma, very prominent, plump pink cells, and just the smallest little hints of small glandular spaces, very atrophic almost, or diminutive glandular spaces. So that should be kind of our reference for normal. But in this particular situation, I think we can see that we have some additional complexity here. And so as we look at this more complex glandular proliferation, the cells don't look too bad. There's a minimal amount of variation in nuclear size. There's no prominent nucleoli. These cells show, a little bit more tall columnar appearance, but there's no marked hyperchromasia. There's no significant pleomorphism or pronounced atypia that we would associate with carcinoma. There's no necrosis, just this glandular complexity. But in this setting, where a patient has had prior diagnosis in a non-progestationally impacted endometrium of an endometrial intraepithelial neoplasia, these findings are diagnostic of residual intraepithelial neoplasia and should be pronounced as such, should be rendered as such in your report, because this patient, once that progestational effect is stopped, is at risk for developing further progression or at least a recurrence of the endometrial intraepithelial neoplasia. Now, this is a rather pronounced area. We have a lot of the atypical glandular tissue in this sample. I'll just move out a little bit more here and let you see some of the other areas. So here's another gland over here. Oops, where is it here? Here's some more here with this prominent, slightly heaped up epithelium. Again, no hyperchromasia, no significant nuclear atypia, but just an abundance of epithelium. This is still residual intraepithelial neoplasia in this patient. As I mentioned, sometimes this change can be rather focal. It may just be a small area of altered glands in one fragment, or even in some situations, just a small area of papillarity on the surface that catches your eye as being slightly different. Here you see this papillarity here. And these all qualify as residual intraepithelial neoplasia with the pronounced progestational effect, in this case of a intrauterine device, a Mirena. So in this particular patient, her follow-up biopsy was at 1 year. She'd had one previous biopsy, which was reported as normal, and one previous biopsy that had been reported as showing residual disease, not, however, as prominent or extensive as seen in this situation. I don't know which of the various risk factors for recurrence that she specifically had, but any of these certainly could have been the situation. I don't think it was this last one, however. So in summary, our sign-out diagnosis in this case was that of residual or recurrent endometrial intraepithelial neoplasia with a pronounced progestational treatment effect consistent with the intrauterine Mirena IUD. Well, that brings us to the conclusion of this brief case. I hope this will be useful to you and that it'll help you to recognize EIN when it presents in the post-therapeutic stage. It's certainly a challenge for us at times. If you like that, you know the drill. Hit the like button and share your comments. And of course, we always hope you'll be subscribed to the channel so you'll catch future releases from our vast array of interesting and sometimes challenging cases. So until next time, thanks so much for joining me.